Hello, welcome to Myers Counseling Group Podcast. We offer mental health, substance abuse, and wellness information for the community. To find out more information and to access previous podcasts and other resources, visit us at myerscounseling.com. Hello, today I would like to welcome Leah Scanlan. Leah is a coordinator with Aspen Counseling and Consulting located in Rockford, Illinois. Leah manages the day-to-day clinical operations for Aspen Counseling, as well as a coordinator for the TMS Referrals and Treatment Program. Welcome, Leah. And my first question to you is, what exactly does TMS stand for?
TMS stands for Transcranial Magnetic Stimulation.
What does your organization do?
Aspen Counseling and Consulting is affiliated with Rosecrance Health Network. We're based out of Rockford, Illinois, and that's indeed where we are located. We're actually inside the Rosecrance Berry campus out on the east side of town, pretty close to 90 and 39 at that intersection there.
Just for the sake of clarity for our audience, TMS is also referred to as Transcranial Magnetic Stimulation. For the most part during this podcast, we will be referring to it as TMS.
Right.
Can you tell us about TMS? How's the procedure work?
TMS is a form of treatment that was developed about over 20 years ago now. It's been FDA approved, though, since 2008, so we're going on 10 years. It is a treatment option for patients with severe treatment-resistant depression. Many of the folks who come through our door have tried every antidepressant under the sun, and many they've been unable to tolerate, or the side effects have just been too much for them to handle, or they just haven't been effective. They've also tried other treatment modalities such as, CBT or DBT therapy. Some of them might have even tried ECT, electroconvulsive therapy, as an option to treat their depression, and they just haven't found any relief, and they still continue to struggle with severe depressive symptoms. So what TMS seeks to do is to stimulate an underactivated part of the brain, a very small part, about the size of a quarter, in hopes of facilitating neurotransmitter release to help enhance the medication regimen that they may already be on, or just to help provide some relief to their symptoms.
Would it be considered a first line of treatment option, or is it usually something that's done after other treatment modalities have not been effective?
After treatment modalities have not been effective, typically it is not the first line of treatment, and it could be considered a first line of treatment. However, as most insurance plans cover TMS therapy now, their requirements in order to authorize this treatment state that the patient needs to have tried usually at least 4 antidepressant medications, along with what we call, adjunctive therapy medications, so some meds that might be considered off-label for depression, but may help in improving those symptoms in the short term, and that they also want to know that the patient has tried a recognized form of psychotherapy, such as CBT or DBT.
Usually a progression of treatment
Correct.
That they look for before.
Correct.
Okay.
Most of the patients that walk through our door have been in treatment for anywhere from 5 to 25 years.
Oh, okay.
Yeah.
Walk us through, if you don't mind, the procedure. So they walk into your building, and what happens after that?
Well, if a patient is referred by their psychiatrist for TMS, which is a majority of the time is how we get our referrals, but they can also be self-referred if they've been in treatment and they're just not experiencing any improvement in symptoms. If they contact us, usually I would set up a consultation with the patient. We would gather a lot of their clinical history and just sort of determine if they're a good candidate, go through some of the contraindications for therapy, some criteria that would sort of disqualify them as a candidate for TMS, and then determine if they would be an appropriate referral going forward. I typically take care of the record request procedures and needing to get documentation from their current treating clinician, psychiatrist or therapist. And then I would, of course, make sure that their insurance plan does cover the TMS therapy. If they need authorization, I would take care of that piece as well, making sure that the therapy is approved for them in order to start. Once they're able to start, they would come in for their first session, which is called the motor threshold or initial delivery session, where our psychiatrist, Dr. Raymond Garcia, is trained and certified in TMS and oversees our program here. He would meet with the patient that first day, and he would do what's called the motor threshold determination. So he's trying to find two things, usually. Number one, the specific treatment location in the patient's brain that we're looking for, and number two, the treatment strength.
So the location may differ from patient to patient?
Yes, it is different from patient to patient because, of course, each patient's brain is structurally different. Folds are in different places. The position of the motor strip is different based on, of course, if we have somebody that's very petite and just naturally has smaller features, and versus somebody who may be 6'4" and 250 pounds. So it really does vary from patient to patient. And the way that we find the treatment location is actually involving the motor strip in the patient. We're actually looking for the specific area on the motor strip where that causes the patient's right thumb to move. And 5 centimeters in front of that location is actually where we're aiming for. It's the dorsolateral prefrontal cortex, and that would actually be the treatment site.
Mm-hmm. How long would the actual procedure take?
Sure. So the actual TMS therapy system is a chair that the patient is positioned in. It looks sort of similar to a dentist chair, where they are actually reclined back, but they're boosted up a little bit higher than the typical dentist chair would be. And behind them would actually be the components of the machine that, of course, power it and power the magnet, and there's a fan that keeps it cool and all of that. So the patient is not seeing the machine in front of them or any of those components. There is a software component to the machine that actually monitors each patient session and makes sure that we have good contact on the patient's scalp with the treatment coil that has the magnet in it. And so when the patient is in the chair for that first session, we usually schedule about an hour and a half to give time for the doctor to find those measurements, determine the treatment location and the strength, and then they actually go ahead and have their first session that day, their first treatment session. So when the patient is reclined back, the treatment coil would sit on the left sort of upper part of their scalp. Mm-hmm. And so because that is the side where that target area is that we're trying to activate in the brain. And so there's a paper strap that we usually place over the patient's forehead just to keep keep their head from moving around too much and keep it as stable as possible, so that we always have good contact during the session, because that definitely affects the efficacy of the treatment. And so that's about it. So there's really none of that claustrophobic sort of feeling. There's nothing holding them down necessarily. They're able to just recline back and be in a comfortable position. And the treatment coil would just be resting on their scalp.
And how long does it take?
Each session takes about 37 minutes and 30 seconds.
Okay.
And I know it's a very specific number, but the reason that is that it's determined through the clinical trials and research that the optimum number of pulses per session that we need to achieve is 3,000.
Okay.
So the way that each session works is that the patient receives 40 pulses. It's called a pulse train or a burst of 40 pulses. They're very, very fast. Succession. It's 10 pulses per second for 4 seconds. So you can imagine it's very quick. And then in between those pulse bursts, they get a 26-second break where they're not getting any pulses at all. They're just laying there. And so when you combine those time intervals together to get to 3,000 pulses, it takes 37 minutes and 30 seconds.
Okay.
And so now, depending on the treatment strength that is determined, or the intensity of the magnetic fields that are transmitted to the brain, we can actually, as the patient tolerates the treatment and we know that they're doing okay, we can actually lower the time of the session, sometimes to as down as quickly as 20 minutes they can get in and out. And if they have a higher motor threshold, usually we have to keep it at that 37 minutes and 30 seconds.
Okay. But it won't go any longer than that?
Typically,
as a rule?
No.
Now, with ECT, electroconvulsive therapy, there's usually side effects, recovery time. I know short-term memory loss is not unusual, a little bit of disorientation. Could you tell us a little bit about what a patient may experience once they've completed one round of treatment with TMS?
Absolutely. So typically, and this is, I think the exciting part and why TMS has become more mainstream, because there really are no side effects. There's no pre-op or post-op procedures. There's no sedation. There's no anesthesia. There's really nothing. We often have patients that come straight from work. They come in, they sit in the chair, they have their session, and then they leave and go home. We have patients that come in before work, from all walks of life, all sorts of responsibilities. They come in, they have their session, they can go about their day-to-day activities. So there's no, preparation or recovery time that's involved with this treatment. So typically, the first session can be, can cause some temporary discomfort. They may feel some soreness at the site where they're being treated on the scalp, because, of course, these magnetic pulses were targeting that area of the brain and the neuronal pathways there. But, of course, this energy has to travel through bone, muscle, tissue, all of that. And so those muscles that have never been stimulated before, it's like any muscle, you work it out and you've never used it, it's going to be a little sore. Right. And so sometimes patients will experience that. They might experience a mild headache after the first session, and usually the symptoms resolve very quickly. Those muscles acclimate very quickly. And even by session number 2, they report that it's much more tolerable.
And for what you had discussed, the TMS being later form of intervention, compared to ECT, which has some significant side effects, it sounds like the side effects with TMS are relatively mild. Absolutely,
because this treatment is a localized treatment, whereas things like ECT and antidepressants or psychotropics are systemic. You're feeling, referred maybe side effects or symptoms from that treatment in other ways. I mean, we've had folks that have had many ECT sessions who didn't really seem to benefit from it and who have benefited from TMS. They come in and say, the biggest side effects I always hear is memory loss with ECT. We've had patients that have reported blood pressure problems as a result of ECT, vision problems, and so nothing like that is related to TMS treatment or has really been reported with TMS treatment. And they've done over 10,000 treatment sessions in the course of their clinical trials, and the clinics around the country, of course, that do this.
There's the minimal recovery or side effects that you would experience from that. How long before somebody may start seeing some of the benefits for this treatment?
That's a good question. So in the clinical trials that NeuroStar did for the TMS therapy, I think the average was about 4 weeks in. We've had some patients here that have seem to experience improvements a little bit sooner than that. But I would say the average is probably 3 to 4 weeks as far as when they would start to notice that.
How often is treatment repeated?
So the sessions that they would be having, the 37 and 32nd, that actually they would come daily. It would be 5 days a week. And it can be anywhere from 3 to 7 weeks. 15 to 20 sessions, I think, was studied when they did the trials. Here at Aspen, we usually go a little bit beyond that, and we have had success with insurance approving up to 36 sessions, and so we usually do that. So that takes you closer to 7 or 8 weeks. Some insurance plans require that you have a tapering period at the end, meaning that if they're coming 5 days a week, they slowly start to taper, so then that maybe the last few weeks they're coming 4 days a week, then 3, then 2, then 1, before they stop treatment, just to kind of wean them down. So it's really up to the patient. Of course, we have a lot of patients that are working. They have family obligations and things like that. So we work around those whenever we can, and we find a treatment protocol that works for them.
Now, again, I'm comparing this to ECT because a lot of my patients have gone through that. And with ECT, you'll have a treatment segment that could last 4 to 5 weeks. Again, could vary. And once they're done, it's not unusual for a few months later for that to be repeated. What do you guys go through cycles with the TMS, or is it usually one time? The first rung of treatment should usually be the most effective.
Usually the first round is the most effective. So we do that full treatment protocol, and then we actually use the standardized scale, the BDI, to measure progress. We usually administer that weekly, and so we really have sort of a good picture of, the progress that was made, if any. And then usually we try to follow up with the patients in 6 months to a year. Typically, if they're going to experience an improvement in symptoms, the data shows that after about 6 months, only 11% of patients who've received this treatment experience some kind of relapse in symptoms. And so the patient can come back and receive more sessions. We do what's called maintenance sessions, where we can do anywhere from 15 to 20 additional sessions, sort of as a booster if they would need that. And in many cases, I think it's becoming more the case is that insurance has approved patients to have another full treatment protocol. It depends on the plan. Some you have to wait 6 months. Some you have to wait a year or more. And of course, they want to see that the first protocol that the patient had an improvement, or demonstrated at least a 50% reduction in depressive symptoms based on the BDI scale.
Okay, and for our audience, BDI is Beck's Depression Inventory, I'm assuming.
Yes.
Got it. And that's a standard depression inventory scale that people in our field use. Usually the first round is what's going to be the most effective. Sometimes in some circumstances a second round of treatment may be presented.
Right. The data typically shows that if the patient does repeat the treatment protocol after they've had a successful first one, that they have an 85% likelihood that they will respond positively to the second round as well.
Oh, okay.
Or subsequent rounds after that.
Would they stop their medication if they're taking a medication, or if they're in any kind of other treatment, counseling? Would those be things that we would usually stop while we're doing this?
No, typically not. We would actually encourage that they continue their treatment regimen with their clinician. So it's important for our patients to know that because Dr. Garcia is our TMS sort of specialist, psychiatrist here, he wouldn't be taking over their treatment. They would continue to see their psychiatrist and stick with their medication regimen and continue to see their therapist or psychologist or whichever clinician they're seeing for counseling. The reason that we, of course, want to encourage that is that if they're starting a TMS protocol, to stop their medications may sort of skew the results a little bit, and we try to encourage patients to hold off on starting any new medications when they start this treatment, so that we really know which is helping them the most. We really can get a sense of if the TMS is effective for them.
Any types of mental health issues that it could possibly be used for?
There is emerging research on that. Currently, it is FDA approved and cleared for the treatment of major depressive disorder only. Okay. But there is some emerging research regarding the use of TMS treatment for addiction, substance abuse disorders, and they recently completed, Neurostar recently completed a study on adolescents to determine if this was as helpful for adolescent depression as it is adult, and I think the results are fairly similar to what they found with adult treatment, because it's currently approved for ages 18 and older. But there is a lot of research that's going into, especially using it for the treatment of cognitive deficits, things related to depressive syndrome and organic brain disease and things like that. So while it's not cleared for any of those, and it would be, if it was used to treat anything other than major depressive disorder, it would be considered an off-label treatment. But for right now, and as far as getting insurance to cover it, we have to stick to the major depressive disorder.
But the research is encouraging that the potential for using it for other types of mental health or substance abuse challenges.
Yes, and there's some concern specifically along the lines of treating like bipolar or folks that experience psychotic symptoms, just because the research isn't there yet to show does this help or hurt. Especially with bipolar, it runs some risk of possibly launching the patient into a manic episode, and I think they're still working on trying to figure out if that would be effective. You
mentioned for adolescents the possibility or for being considered. What are the age parameters? Is there a ceiling to this? Are elderly able to partake in this type of therapy?
Yes, we have had some older patients that have received this treatment and have found it to be helpful. Right now it is approved through the FDA for treatment of patients 18 and older. So there's a couple things that we like to rule out when we consult with the patient at the beginning. The treatment is definitely not recommended for patients that have a diagnosis of Alzheimer's, dementia, or Parkinson's, or other, serious traumatic brain injury, or other serious organic brain diseases. So it's definitely not recommended for that. Also for patients that have a seizure disorder, patients that have any implanted pacemakers, shunt stimulators, VNS, any bullet fragments, aneurysm clips, any metal that's implanted in the head, this would not qualify for this type of treatment because, of course, it is electromagnetic.
You've given us a whole lot of information here, very helpful information about TMS. And once again, if you could tell us the name of your organization, and if you also have a website you could give us so people could look up some information about your organization as well as the treatment.
Yeah, so again, I'm Leah Scanlan. I'm the coordinator with Aspen Counseling and Consulting, and we're out of Rockford, Illinois. We do have a website. It's aspenbh.com, BH for behavioral health. So aspenbh.com. There's lots of TMS resources and videos and information about TMS and how to get started on our website. You can contact me directly. My direct phone number is 815-332-6082, and I return calls very promptly. The consultation that I mentioned is free. We don't charge for that, so it's just a matter of I like to bring potential patients in to see the chair, get a feel for the treatment setting, and get all questions answered and make sure everyone's as comfortable as possible with the treatment going forward. Just wanted to point out as well, as far as insurance coverage goes, so most of the major medical plans out there do cover TMS. Medicare also covers TMS. Mm-hmm. So, and that was sort of a development in the last couple of years and was really sort of a hindrance for folks that were trying to get this treatment that may be on disability just because of the severity of their depression. So that definitely is an option. Medicaid, unfortunately, has not come around yet to cover it. Some other states, the Medicaid does cover it, but not in Illinois, unfortunately. So, yeah, I mean, it's definitely, like I said, more mainstream, and I think a really safe, effective option. The efficacy is about 1 in 2 patients tend to respond to the treatment, respond favorably. Mm-hmm. And we've had some patients in the past that were able to go into complete remission. They didn't need to take antidepressants for their symptoms and were able to find some really good relief from this procedure.
Excellent. And usually they would talk to their either primary care physician or psychiatrist to get pointed in a direction to receive this type of treatment.
Yes, and they can be self-referred too. They can reach out. Typically, though, if we're going to be requesting insurance to cover this, they do want to know that the patient has attempted antidepressants in the past, and so we would need documentation of that. So if the patient is currently in treatment with a psychiatrist, they've maybe been in treatment for the last few years, they've tried lots of different medications, jumped from one to the other, and usually there's lots of dosage adjustments, and then they eventually try something else. And if what they're doing isn't working, TMS could definitely be a good option for them.
And once we have this posted on our website, we'll have your contact information as well.
Perfect.
And Leah, again, we want to thank you for your time, and we really appreciate all the good information you gave us.
Absolutely. Thanks for having me.